Okay, the learning outcomes for this lecture is the student should be able to define what is interceptive orthodontics, describe the different procedures undertaken in interceptive orthodontics, define serial extraction, outline the advantages and disadvantages of serial extractions, and explain the role of muscle exercise as an interceptive procedure. Okay, let's have a look at what is prevention and what is interception. Now, prevention is indicated in a situation where the malocclusion has not happened but predicted to happen in future, and the aim is to stop the malocclusion from happening. Now, interceptive treatment is indicated where the malocclusion has begun to happen, and the aim of interceptive treatment is to modify or lessen the negative effects of the developing malocclusion. Okay, so let's what is meant by interception. De Linden says that it's the guidance of the development of the dentition through minimal intervention with the aim of preventing, reducing, or correcting existing or potentially abnormal tooth positions. Now, Chung and Kerr says that interception is any treatment which eliminates or reduces the severity of a developing malocclusion in order to eliminate or simplify the need for future treatment. Now, Profit is of the view that interceptive treatment is very helpful in reducing the severity of problems, but rarely is so successful that later stages of treatment are unnecessary. Now, the advantages of early interceptive treatment are one is psychosocial benefit. A lot of patients, for example, with protruding teeth are subjected to uh, teasing in schools, and these children will benefit psychosocially. Also, procline teeth, which are prone to trauma, um, may be reduced incidence of trauma by early interception. Now, the craniofacial tissues are more modifiable at a young age and thus are more amenable to functional corrections. Now, the disadvantages of early treatment is treatment time is proclined, thus cooperation of the patient may decline. Now, soft tissues mature late, according to Wick and Cohen. Thus, doing early treatment does not take into account the soft tissue changes which happens late in development. Now, arch development gained by early treatment is usually lost in the permanent dentition, and early in the developmental stage is difficult to decide on the choice of extraction. Now, to enable to do interceptive procedures, one should be familiar with the normal skeletal and development. They should be able to recognize existing anomalies and reasonable prediction of future possible complications. Now, what is normal? When we talk about normal, we have to recognize that there is a biological variation with normal being a range rather than a single defined uh, characteristic. Okay, let's look at a dental norm. Okay, uh, in the deciduous dentition, the norm is that there should be a complete deciduous dentition, meaning no missing teeth. Mild spacing should be present with primate spaces. Edge to edge incisor relationship should be present. There should be no crossbites, and the molar relationship should be flush terminal relationship or a mesial step. Flush terminal plane or the mesial step. The distal step generally leads to a formation of a class 2. Now, the skeletal norm is we want a class 1 relationship with a straight facial profile. Jaw relationships should be balanced in the vertical, transverse, and anterior posterior plane. Okay, functional norms, we want to see a normal swallowing habit, nasal breathing, and preferably not oral breathing, and there should be no habits, especially digit sucking habits. Okay, now the role of prevention and interception is very difficult to clearly define what is prevention and interception, as there's a lot of overlap, but the role for prevention is much smaller compared to interception. Okay, very few procedures are purely preventive. Now, the etiological factors involved in a malocclusion are skeletal factors, soft tissue factors, and local factors or dentoalveolar factors. Now, skeletal and soft tissue factors are under genetic control, and therefore there's less scope for intervention when the etiology is skeletal or soft tissue. Now, local factors or dentoalveolar factors or environmental factors are more, more amenable to interception and can be modified. Okay, the timing for interceptive treatment is during the mixed dentition, and this is the period where the dentition transitions from a deciduous to a permanent dentition. Okay, now what are the possible problems that can happen in the uh, in, in a developing dentition? Okay, there are a lot of many factors, but some of the common problems that can arise can be grouped under three big groups. One is local factors, we have soft tissue or habits, abnormal habits, and we have skeletal factors. Okay, let's have a look at each of them. Okay, under local factors, we can have eruption anomalies that can be delayed or non-shedding of the deciduous teeth. Now, deciduous teeth are normally shed when the root of permanent successor is about 3/4 complete. Now, a delayed eruption is caused by necrosis of deciduous pulp due to caries or trauma, and the necrotic deciduous tooth is usually difficult to doesn't resolve easily. Now, this can result in displacement of the permanent tooth, leading to a impossible anterior crossbite. Now, the treatment is to extract the retained deciduous tooth as soon as possible to allow the permanent teeth to align. Now, supernumerary teeth. Supernumerary teeth means extra teeth apart from the normal teeth in the series. Now, it is usually more common in the permanent dentition, more common in males. There may be a hereditary element to it, more common in the maxilla, and 80% of them are found in the anterior part of the maxilla. It can be a erupted supernumerary or conical supernumerary, or it may not be a unerupted supernumerary, which is called a tuberculate supernumerary. Now, a supplementary supernumerary resembles a tooth of a normal series, and this, when it happens in the posterior part of the arch, it is known as a paramolar. Now, the effects of supernumerary teeth are It can cause spacing or diastema. It can cause displacement or rotation of the permanent teeth, and it can also interfere with the eruption of permanent. This is the picture of a mesiodens. As we can see here, because the mesiodens has taken the place of the upper left central incisor, therefore the upper left lateral incisor does not have space to erupt in the arch and has been displaced palatally. Okay, now what do you do when you see a supernumerary? Now, the treatment of choice is to extract the supernumerary, but you have to consider also extraction of the non-supernumerary if the normal tooth is carious. For example, here we have a lateral incisor and a supernumerary, which both are similar. So therefore, the extraction choice should also be based on the condition of the tooth and not just which is supernumerary and which is a lateral incisor. Okay, if an extraction is to be done, the earlier the tooth supernumerary is extracted, the more chances of spontaneous eruption of permanent teeth. Now, if we look at these two OPGs, both has got supernumerary mesiodens in the midline. But in the OPG above, we can see that the canines have not erupted, and whereas in the OPG at the bottom, we can see all the permanent teeth are erupted. Now, if we extract this mesiodens, it is more likely that the diastema will spontaneously close in the case in the upper OPG, as the canines have not erupted yet. Okay, now delayed eruption of a permanent incisor. Now, usually this is caused by the late shedding of a deciduous incisor or an early loss of deciduous teeth resulting in a thick fibrous covering. And there may also be presence of supernumerary teeth or odontomes which interfere with the eruption of the supernumerary teeth. Okay, now if the unerupted tooth is superficially placed, we can excise the mucosa and create a window for the eruption. In this picture, we can see that the window is being created using a laser. Now, if it is deeply positioned, then the tooth need to be exposed and bonded with a traction chain. Now, impacted canines. Now, the canine is the second most commonly impacted tooth after the third molars. Now, why is this? Because it has a long eruption path. If you can see this picture of the human skull, you can see the canines are situated very far from the arch. Okay, and is usually, if it's ectopically positioned, it can result in infection and is commonly associated with microdon or missing lateral incisors. There may be a hereditary element to it. Bulk of the unerupted canines are palatally placed, that is about 85%, whereas 15% are buccally placed. Now, the preponderance is higher in females compared to males, and most of them are unilateral compared to bilateral. And in about 12% of the cases, resorption of the root of the lateral incisor occurs. And the deciduous C may be retained. Okay, and there is a lack of palpable canine bulge. Findings. Okay, here we can see the unerupted impacted canine seen in the OPG. Now, this is a upper anterior occlusal, showing another view of a unerupted impacted canine. Okay, here we see a microdon lateral incisor and the canine, permanent canine on the same side is absent. Okay, what is the treatment for impacted canine? Now we'll need to extract the deciduous canine and if necessary the deciduous bees as well. Okay, if space for eruption is sufficient, then maintain the space. Now, if there's not enough space for eruption of the canine, then consider extracting the first premolar to create space. Extract the C as early as possible. Spontaneous eruption more likely if a root of impacted canine is not complete or not mature. Okay, anterior diastema. And the incidence of anterior diastema varies according to age. The incidence at 6 years is about 98%, 11 years it drops to 49%, 12 to 18 years it's 7%. Now, if it is the diastema is less than 2 millimeters, it may be a physiological diastema, and this is commonly associated with what is known as the ugly duckling stage. Okay, if the diastema is more than 2 millimeters, then possibly it may be pathological and it may be due to a presence of mesiodens or odontomes. It could be due to a thick, lowly attached labial frenum. Okay, or there could be a microdontia or hypodontia. Now, the treatment for the anterior diastema is to establish the cause and advise and reassure the patient if it is physiological, remove any obstruction present, and do a frenoplasty after the mid diastema is closed. Now, serial extractions. Now, serial extractions are sequential extractions done over average of 5 years. The aim of serial extraction is to relieve anterior crowding. Now, serial extractions are usually done in the upper arch because in the lower arch, extractions may result in lingual collapse of the lower anterior segment. Okay, the serial extraction sequence as specified by Kjellgren and Duell is first to extract the Cs to allow eruption or alignment of the permanent lateral incisors, followed by the extraction of the first deciduous molars to allow eruption of the first permanent premolars, and subsequently the first premolars is extracted to allow eruption of the permanent canine. Now, the indications of serial extractions are lack of space or reduced arch length, a severe class 1 malocclusion, patient is in the mixed dentition with a normal overbite, all the teeth are present and sound, and very importantly, the form should be developmentally ahead of the canine. Probably due to a skeletal problem and is usually associated with a skeletal class 3. It may be a true class 3 or a pseudo class. Okay. Uh, when it involves 1 to 2 incisors, now it's commonly caused by dental or local factors. It may be caused because of displacement by supernumerary or odontome. There might have been due to trauma to the deciduous incisors, leading to retained deciduous incisors. And usually, if there's crowding, the lateral incisors are in standing. Now, the effect of This crossbite is due to space loss due to arch contraction, gingival trauma, and mandible deviation on closing, leading to future TMJ problems. Now, if space is available for alignment of the tooth in crossbite, then a few measures can be taken. One is to use a tongue blade therapy. The disadvantage of this is it depends heavily on patient compliance. The tooth should be partially erupted. The tongue blade should be used minimum 5 minutes per hour, but the success rate for the tongue blade is poor. We could also use a lower bite plane, also known as a Catalan appliance, with acrylic cemented on lower teeth, or it may be on a removable lower appliance. It has a 45 degrees bite plane, only touches the displaced tooth, and it's used for a short period of time for about 7 to 10 days. Now, the other ways we could use is a upper removable appliance or a fixed appliance. Now, with a removable appliance, we can either use a cross cantilever springs, we can use single cantilever springs, or we can use a double cantilever or Z springs. Okay, also with a removable appliance, we can use a screw plate. Okay, now posterior crossbite. Posterior crossbites are basically abnormal buccolingual relationship between upper and lower posterior teeth when they are in occlusion. There are two types. They may be dentoalveolar, which is due to local factors, or it could be a skeletal crossbite, and this is usually due to a narrow maxilla or a wide mandible or a combination of both. Okay, and posterior crossbites can be either unilateral or bilateral. In the picture on the left, what we see is a unilateral crossbite, whereas on the right, we see a picture of a bilateral crossbite. Now, posterior crossbites to be treated early to allow normal development of the dental arches and temporomandibular joint. Now, when you have a single molar in crossbite, we can make use of cross elastics, and this is simply elastic which runs from the palatal side of the upper molar to the buccal side of the lower molar. These elastics are worn full time for about 3 to 4 months. Okay, we could also use removable appliances utilizing posterior occlusal coverage. We can use a screw appliance, we can use a coffin spring, or we can use a removable appliance with a T-spring. We could also, the screws can also be a sectional screws to move just one tooth out of crossbite. Now, we could also undertake slow expansion with fixed appliances. Example of these would be a quad helix or a nickel titanium expanders. Now, rapid expansion with fixed appliances are done utilizing a high-rise screw and is usually indicated for severe cases of bilateral crossbite where the aim is to obtain skeletal correction. Now, what this does is it splits the mid-palatal suture, and thus it is more effective in a growing child where the mid-palatal suture has not closed, and preferably before the child is 9 years old. It's the turns on the screw is done 2 turns per day, and as the treatment progresses, an anterior diastema appears, and this should be warned to the parents. The parents should be warned about this so that they do not get anxious about the opening of the diastema, or either to close or open the space. Now, if space is not maintained, teeth will drift, and tilt, and this will result in a loss in arch length. There may also be centerline shifts, okay, and primary and permanent teeth will be crowded out due to lack of space, and they may also become impacted. And once this is happens, it will need comprehensive treatment with extraction of teeth. Now, the effect of loss of deciduous teeth, two effects can be considered. One is mesial drifting of adjacent teeth and the midline shift. Now, loss of A and B has relatively insignificant effects on the arch, but um, the loss of the posterior deciduous teeth results more in mesial drifting, whereas the loss of canines result in midline shift. Now, space regain. If D and E are lost early, the first permanent molar drifts mesially, resulting in a reduction of arch length. Now, space can be regained by moving this first permanent molars distally, but this has to be done before the eruption of the permanent second molar. Okay, one way of regaining the space is to use a Gerber space retainer, as shown in the diagram here. Okay, it has a band and it has an arm and it has got a coil spring to push the molars distal. Okay, we could also use a jack screw appliance, or we could use a removable appliance using cantilever springs. Habits. Now, digit sucking and pacifier use. Now, these are common habits in young children. They are usually normal as long as the patient is about age 3 and below. Now, the effects on the dentition on prolonged digit sucking and pacifier depends on how frequent is the habit, the intensity of the habit, that is the force exerted by the digit, the duration of each episode of uh, the habit, and the method, whereas it is by whereas it is the thumb finger or the use of a pacifier. Now, the effects of digit sucking are it causes an open bite, proclination of the upper incisors, retroclination of the lower incisors, posterior crossbites, and adverse effects are minimal if it is stopped before 6 years of age. Okay. Now, this is the development of the anterior open bite and the posterior crossbite. Now, the posterior crossbite develops because the tongue, the digit in the mouth will displace the tongue downwards, and the sucking effect of the digit causes the uh, buccal musculature to press against the upper posterior teeth. Now, since the tongue is low in the oral cavity, it cannot counteract the pressure put on the upper buccal teeth, and thus it will develop into a crossbite. Management of digit sucking. Now, spontaneous correction occurs if it stopped before 6 years of age. Now, parental involvement is important, and the child should be encouraged with a reward system to stop the habit, and should be supplemented with a lot of praise. Parents should be reminded not to nag the child, and he can do what is habit reversal therapy. Now, the aim of management is to uh, provide a reminder therapy, and this can be done by using a finger bandage, finger pain, boxing gloves, or thermoplastic finger pose. Okay, a habit breaker appliance. Now, it's important it functions as a reminder. The child must want to stop the habit for the habit breaker appliance to be effective. Should be pain free, no occlusive interference. Okay, so these are some of the devices. Okay, this one is a loop on a removable appliance or fixed appliance, and this is a bluegrass. Okay, now tongue thrust habits. Now, in a tongue thrust habit, the tongue makes contact with the anterior teeth during swallowing, causes open bite and anterior proclination. Now, habit breakers help with the swallowing technique. Now, in mouth breathing, this is usually caused because of narrowing or obstruction along the upper respiratory passage, for example, like enlarged tonsils and adenoids. And even after the adenoids or tonsils are removed, the habit can still persist. Okay, a vestibular screen can be used as a habit breaker. Now, some children present with mild protrusion and spaced upper incisors in the mixed dentition, and the lips are frequently hypotonic and flaccid. Now, Rogers proposed various perioral muscle exercises to increase tonicity of the muscles, and these exercises may aid in the self-correction of mild cases. They also prevent the development of abnormal lip and tongue habits that worsen the malocclusion. The muscle exercises must be done at least 30 minutes a day for 4 to 5 months. Skeletal discrepancies. Now, skeletal discrepancies are they caused by the genes or environment? Now, the final jaw size and shape is believed to be in tight genetic control, but the question arises whether growth can be modified. Now, functional appliances, as I said, since growth is under tight genetic control, whether these appliances are effective is a debatable issue. But there may still be benefits to using functional appliances as this reduces chances of injury to procline incisors. It utilizes the pubertal growth spurt for its inducing growth changes, but the difficulty in utilizing this modality is that it's difficult to predict the growth spurt timing, and a high level of patient compliance is needed for its success. Now, in class 2 excessive maxillary growth, we can use a face bow with an headgear. And in class 2 deficient mandibular growth, we can use myofunctional appliances. Okay, in class 3 deficient maxillary growth, we can use a reverse face mask or Frankel regulator 3. In class 3 excessive mandibular growth, we can use a chin cup with headgears. A little bit of info on cleft lip and palate. Now, in cleft lip and cleft alveolus, we get what is known as arch collapse, and there's lack of bone for eruption of the cleft side canine. Okay, this picture shows an example of a severe arch collapse in a bilateral cleft lip and palate patient. Okay, now apart from the effect on the dentition, there is also a lack of alar support resulting in distortion of the nose. Now, alveolar bone grafting is a procedure that is done to restore the arch integrity in terms of size and shape. Now, it also provides a bony bait for the eruption of the canine. Now, the timing is critical. Ideally, it should be done when the unerupted canine root is about 2 to 2/3 complete. Now, to recap our lecture on interceptive orthodontics. Now, what is the role of the examiner or the operator? Now, it's the important role is to refer the patient for early treatment when um, such problems are encountered. Now, the operator should avoid causing a malocclusion, worsening the malocclusion due to neglect or inappropriate treatment. Now, management of simple cases can be done by the general practitioner, but it will require a very careful case selection and involves easy cases involving movement of one or two teeth. Now, the references for these lectures are as follows. Thank you.